Hey everybody, my name is Michelle Cardel. I am a registered dietitian and obesity scientist at University of Florida. Thank you so much to Build Up Dietitians for inviting me to be here with you all today. So to start off, I have a couple social media channels that I'd love to have you come on to and engage with me. So I have a Facebook professional page that you can find me at. It's Michelle Cardel, and on Twitter I am Michelle Cardel as well, and on Instagram my handle is Dr. Michelle Cardel. So today I would love to take any questions that you have related to nutrition, obesity, getting both an RD and a PhD, the path for those things, any questions that you all have. I'm really happy to answer anything. Before we start, I'll give you a little bit of information about both my research as well as kind of where I'm really engaged in the societies. So first off with my research has really two areas right now. So I have a lab with a full-time research coordinator, PhD student, 2 master's students, and several undergrads. I have 8 undergrads in the lab right now. And our focus is to really do 2 different things. One, we look at how psychosocial factors like food insecurity and low social status affect people's eating behavior and their risk for obesity. And then the second component of our lab is focused on developing and implementing effective, healthy lifestyle interventions for adolescents with overweight and obesity. So I love my job. I love what we're doing. Most of my time is focused on research. About 80% of my time is research focused, but I also get the privilege to teach students, primarily PhD students, and individuals who are already physicians. Those are the people that tend to take my courses. I feel like this is rocking. Is that better now? Because I had it on my lap. I was trying to make it more comfortable for you all so we could see better. But so any questions that people have, I would love to take. While questions are coming in, first off, some organizations that I'm really heavily involved in that I think that are really wonderful venues for registered dietitians is the first is the Obesity Society. So if you're at all interested in treating patients with the disease of obesity or doing research in that area, the Obesity Society is a really great society to be involved in. I got involved with the society, I think my first year as a PhD student, so in 2006. I've been a member of the society for about 13 years now and have done all different components, including diversity committee, early career committee, audit committee, nominating committee. Now I'm the chair of the population health sciences committee for program committee. So we're helping develop the track for that. And then the other society that I'm really involved in is the American Society for Nutrition. So this is also a great venue for registered dietitians to go to. They have clearly a big focus on nutrition, and they really span the research side as well as the clinical side, which the Obesity Society does as well. I was the chair of the Obesity Research Interest section a couple years ago, and just have really enjoyed going to those meetings. And, you know, I think it's a wonderful way to meet other dietitians, particularly if you're interested in, doing any sort of research as part of being a dietitian, or the clinical side. If you want colleagues to build up basically a network of colleagues who are doing similar work to you. So if you're working a lot with patients with obesity, so for example, if you work in a bariatric surgery clinic or something like that, going to Obesity Week, which was just last week in Las Vegas, is a great opportunity for networking and to meet other people who are like you. So any other questions that people have? I got some questions ahead of time, so I will just go ahead and start answering some of those. So one person asked, what was my path like to get an RD and a PhD? So this is a great question. I took a very non-traditional path. So my background, hi Nancy, thanks for joining. My background was an undergraduate. I had a degree in biology and chemistry, and I worked as a hospice volunteer. And I started doing that when I was about 19, I think. And in doing so, I learned so much. It's truly a privilege and an honor to be at the, be with people basically at the end of their life. And during that time, people really tend to share things with you. And one person, told me one time that they were worried that they had killed themselves with a fork. And that was the first time I'd ever heard that term. And that was the first time I'd ever thought, how the choices that we make today can influence our quality of life later on down the road, and even how we end up dying. And after that first person said that, over the course of the, I think I was a hospice volunteer for the next 8 or 9 years, I heard that several times, that people were worried that they had killed themselves with a fork. And that was really what sparked my interest in nutrition and why we eat what we eat, and why do we choose it, and how does culture and upbringing and social norms play a role, and also how do the resources that we have access to influence what we eat. And so I graduated from college. I went and did what any responsible person who doesn't really know what their career path is going to look like did. And I just went and backpacked Europe for about 6 weeks. And I applied for graduate school from an internet cafe in Prague, paying by the minute. So that definitely ages me. But I thought, okay, if nutrition is really impacting these people and how their end of life care occurs, I want to be part of that. And so I started off doing a master's in nutrition at Florida International University. And my partner at the time was in medical school at University of Alabama at Birmingham. And UAB, when I looked it up, had the second best nutrition program in the country at that time. And so I decided to apply and got in, which I was thrilled about, and started a PhD there about a year after I graduated from undergraduate. And so I finished my master's in clinical nutrition there at UAB. And about halfway through my PhD, I decided I wanted to be a registered dietitian. I really felt like I was missing this whole clinical side to my work. And the research part was so interesting and so important, but I felt we really needed to understand, how does this actually work in the real world? How does this actually work with patients and counseling patients and doing all the exciting and wonderful things that registered dietitians do? And so I went to my mentor, my PhD mentor, who is a statistical geneticist by training. And I asked him how I could make it possible for me to do an RD during my PhD. And he basically told me I was crazy, that was a terrible idea, that I would fail. I would fail at something. I would either fail during the RD or I would fail in my PhD and not be able to finish, that it was too much. And then on top of that, because I didn't have a background in nutrition, I had to take 55 additional credit hours before I could even qualify for the dietetic internship. And so he said if I got the support of my committee, he would allow me to do it. But it was not the course of action that he recommended. And I said to him, this is something I really want to do. I think it's going to be worth it. And he said, okay, then go ahead. And I talked to my committee. They approved me to do this. And ultimately, he was right. It was crazy. I did not fail, thankfully, but it was crazy. For 2.5 years, I started trying to complete those 55 additional credit hours before I could, be part of the dietetic internship. And, that I was basically taking additional classes on top of all my PhD coursework. And then once I finally did get into the dietetic internship, I was at the hospital, 40 hours a week, and then doing all my PhD work at nights and on weekends. So though I have never, ever, ever regretted that decision, it's one of the best choices I've ever made, was to do both a PhD in nutrition and become a registered dietitian. It's not necessarily the course of action that I would recommend to others. If you already have, if you're already an RD, then you're leaps and bounds ahead of where I was when I started. You already have great insight. And so if a graduate program is something that you're interested in, I highly encourage you to seek it out, whether it be a master's degree or a doctoral degree, because I think that everybody benefits. You benefit as both a clinician, you get greater insight into the science piece, and the science benefits significantly from having well-informed RDs to be driving the science. So after I did the RD and the PhD, I went on to do a postdoctoral degree in Colorado. So I got to work there with a great group of folks at University of Colorado's Anchorage Medical Campus. I worked at the Health and Wellness Center. It was basically a dietitian's dream place to work. The first couple floors, we had an incredible fitness center there. We had an organic cafe that served really great healthy options. We had a grocery store where we could teach people how to grocery shop right there in our building. It was wonderful. We had a garden, a Zen garden on the third floor, and then our labs were on the upper floors. And it was great because the culture there really focused on wellness. And so, I'd work all morning, then around noon, I'd go down for a yoga class or a Zumba class and, feel great, take a quick shower, and then go back up to the Health and Wellness Center for, finishing the day and finishing whatever research project I was working on or paper I was writing. And it was a really great way to work and to live. After 3 years of being a postdoc, I took a faculty position at University of Florida in the College of Medicine in the Department of Health Outcomes and Biomedical Informatics, and that's where I currently am. I've been there for 4.5 years now, and it's been a really wonderful place to grow and thrive as both an academic as well as a registered dietitian. I've gotten to work in the pediatric neuromuscular clinic, helping kids with Duchenne muscular dystrophy when, they often get put on steroids. And it's a real struggle for the kids, for their families, because the steroids make them hyperphagic and they gain a great deal of weight, particularly adiposity or fat. So working with the parents, working with the families, and how to improve health. Before I continue on that, I just want to stop and see if there's any other questions that are coming in. Nancy, do you have any questions to ask? Well, while questions continue to come in, I will tell you about working with kids with Duchenne muscular dystrophy. Like I said, it's a real honor, a real privilege. Okay, let's see. What is your stance feelings about intuitive eating? I asked because another RD with a PhD said PhD RDs don't agree with it. I believe you are referring to, I think it was Kevin's tweet about that. Is that what you're referring to, Sarah? So either way, I also saw that. I think that there's two separate things. There's the intuitive eating, which I think most people can get behind. And then there's the health at every size movement. So I see these as two different buckets. In terms of intuitive eating, I think the data that we have coming out of that seems preliminary but promising. I'd like to see a lot more research and data done in that area. In terms of the health at every size movement, there's a great deal of wonderful components of the health at every size movement. I absolutely believe that we need to treat people with dignity, that weight stigma and discrimination is absolutely appalling. So, there are really wonderful components about the health at every size movement. The component of the health at every size movement that I am not on board with is the component that states that that obesity does not cause increased risk for other health disorders or for other health complications. So obesity is a disease, and just like diabetes, there are obesity-related complications that result. I think the data is very strong to support that, and I believe very much that we need to continue treating obesity. When I work with kids with obesity, and it's interesting to me when I see people really against treatment of obesity in youth, because it is such a struggle for these kids. I'm very fortunate to be able to run a study with adolescents with overweight and obesity. And the therapy that we use is called acceptance-based therapy. And it's very much a comprehensive, multi-component program where the focus is not on weight. It's about health and living a healthy lifestyle. And that includes physical health, mental health, emotional health. And I think it's really important to focus on all components of that. The intervention that we use does include mindfulness. It focuses a great deal on self-regulation skills, values clarification. So identifying what is your value system and making sure that your actions align with your value system. And then it also includes components of evidence-based standard behavioral therapy interventions. So it's basically a standard behavioral therapy intervention plus all these added components on mindfulness. And so it's, to answer your question, Sarah, there are components of everything I think that RDs are doing and promoting that have positives. But we need more data on the intuitive eating aspect before I would make, a sweeping recommendation. But it's certainly not something that that I'm against by any stretch, nor am I, quote unquote, against the health at every size community. I think that folks in the eating disorder world bring up very legitimate points that need to be taken seriously. In regards to treating obesity and the way we talk about obesity, particularly with youth. But I'm not on board with this idea that obesity does not have related complications. So any other questions from anybody out there that want to talk? I have to tell you, this is my first Facebook Live. It's a very interesting experience. Thank you, Sarah, for asking the question. Okay, let's see. Thank you for being on. You mentioned the many social factors which can influence a person's diet. In your research, do you see any specific cultural values or beliefs which contribute to better dietary practices? Thank you, Justin, for that question. So I just finished up a randomized controlled trial that I did in my lab where we experimentally manipulated social status, and we looked at how that influenced eating behavior which of course influences risk for obesity. And what we saw was that when individuals are randomized to a low social status condition, they tended to eat about 130 more calories at the ad libitum lunch buffet meal following. They ate a greater percentage of their calories from saturated fat, about 375 milligrams more sodium. And, you know, I'm probably getting a little bit ahead of myself here because the data is pretty clear that individuals of lower socioeconomic status tend to have a higher prevalence of obesity. And the same goes for individuals with food insecurity. And these relationships tend to hold true mostly for women, but not really as much for men. And so when we see this observational data, people often go to this idea of, well, it's the food deserts, or it's lack of access, or it's a lack of education that's driving these relationships. But up until recently, all of that data was cross-sectional, observational. And so we couldn't determine any sort of causal inference from that data. And so myself and others like Bobby Cheon in Singapore, Bratanova in the UK really sought to characterize what are these underlying mechanisms related to the observational data that we're seeing of lower socioeconomic status being related to poor diet quality and increased risk for obesity. And so what we saw in my lab is that there's something about the experience of being put in a low social status condition that is driving excess calorie intake. And we believe it's very much physiologically driven. Bobby Cheon's group also found some great data to show that when people are placed in experimentally manipulated low social status conditions, that their ghrelin, or the satiety hormone that tells us that we're hungry and we need to eat more, that goes up as well. So, you know, your question was really focused on, are there any cultural values or beliefs that are seemingly protective? I have focused much more on the what seems to be driving adverse eating behavior, because that's the area of research that I'm engaged in. But I think, Dustin, what we do see that in terms of cultural beliefs or practices that lead to better diet, I can speak to some data within the Hispanic population, you know, where within Hispanic communities, and I myself am a Puerto Rican woman, grew up in a, you know, very, very Puerto Rican house. I didn't learn English until I was 5 when I went to school. The centeredness around family and around meal times was very much protective in terms of dietary practices. So there's, you know, pretty good observational data to indicate that there's an association between consuming family meals together and decreased risk for childhood overweight and obesity. And, you know, I think that there is something to that. I think that when individuals are able to place a great emphasis and focus on eating together as a family, that improves diet and dietary related outcomes. So yeah, I would say that's one of the biggest predictors I've seen, both anecdotally and in the literature, that that is a cultural value or belief that tends to contribute to better dietary practices. So, I hope that answered your question, Dustin. And thanks for being on. Any other questions from any other folks out there? If not, I'll go to the list that I had from earlier. Okay, let's see. And Becca, thanks for your comment that hard to believe this is your first Facebook Live. It is very interesting dynamic. So I very much appreciate you all being on. So one other question that I got ahead of time from folks was, let me see it. Okay. What do you think we need to be doing as dietitians for kids with overweight and obesity? So I think that this is a really great and important question. So we have, there's 337 million kids between the ages of 5 and 19 with obesity across the world. And that number is only increasing. So I do think it is incredibly important to have effective treatments available for kids with obesity. And that may include behavioral intervention, pharmacotherapy intervention, as well as bariatric and metabolic weight loss surgery intervention. We recently published a paper in JAMA, basically doing an overview of the effective and currently available treatment options for adolescents with obesity. So if anybody's interested in reading that, I'm happy to share that with you. But ultimately, I think that given the how many kids are struggling with their weight and, the known obesity-related complications that occur that are not just related to the physical components, like increasing their risk for cardiovascular disease, type 2 diabetes, some types of cancer, but it also affects their emotional health and with, discrimination and stigmatization, influencing their social health, leading to, poor body image, self-esteem issues, depression, things like that. So yes, I feel like it's our responsibility as providers to be able to give evidence-based, compassionate care to youth and their families, with the disease of obesity and other related obesity-related complications. So, what other questions do people have? Becca, do you have any questions? I'm just really glad that all of you came to this. It's really nice to see you all. It's really cold here in Florida, which I'm a bit of a baby. It's probably like 55 degrees. I'm sure it's colder where a lot of you all are, but it's gotten cozy and nice here in Florida in the last couple days. So we have about another minute left if anybody else has any questions. If not, we can go ahead and sign off. All right, everybody. Oh, something just came in. Let's see. Okay, Jackie asked a question. So how do you find the right balance to inform youth on healthy weight practices given the social climate around dieting today? Yes, that is a great question, really important question. So people will often ask me, parents in particular will often ask me, how do I talk to my child about their weight? And there's a very simple answer. It's you don't. There is absolutely zero reason to talk to your child about their weight or anybody about their weight. At the end of the day, it all comes down to living our healthiest life. And we know that there is significant heterogeneity and variability around weight. That weight and body size and body shape is very much genetically driven. And so, if we all ate the exact same way and moved in the exact same way, our bodies would all still look very different. And so placing an emphasis on weight rather than on health, I think is a mistake. I think the focus really needs to be on improving our health-related behaviors, like improving our diet, improving physical activity, improving stress management, and other, improving our sleep, which so many of us struggle with. It's in our program, we talk about where do you end up when you're living your healthiest life? And this kind of idea of having like an ideal weight, I think is very damaging for people in the sense of at an individual level. So, on a population level, we can make these recommendations. If you're this height, this should be kind of your ideal weight. But when you're working with an individual, I think it's very damaging. We conducted focus groups in adolescents with overweight and obesity. And when we asked them who is a barrier to achieving health in their life, many of the adolescents said that it was their healthcare providers. They acted out basically pulling out the BMI charts and the practitioner saying to them, okay, this is the red zone. This is where you are. This is the green zone. This is where you need to be. And then saying, okay, now go lose weight. And that is both so incredibly hurtful for youth and also incredibly unhelpful. We would never tell a person with depression, well, just cheer up. We involve them in therapy. We give them medication if needed. Pharmacotherapy is involved. And yet we don't give the same respect to the disease of obesity. And so I think that's one of the real shortcomings. And I'm really happy to see that people are talking about this more, because I think we're moving in the right direction of, rather than focusing on weight in and of itself, focusing on improving our health behaviors. Regardless of what our body size is, we can all be healthier. We can all eat better. We can all move our bodies more, be more in tune, improve our stress, our sleep, all those things. So let's see. I got a question from Becca. With treating pediatric obesity, can you treat the child only, or do you really need to focus on the family unit? A really wonderful question. So in kids ages 12 and under, the data is 100% clear. Families have to be involved. There's no question the data on that. Kids 12 and under are not autonomous. They don't get to go to the grocery store. They don't have transportation. They don't get to, make any of these choices for themselves. And so involving the family unit is essential for changing the home environment and getting, parent buy-in. Something I see that's really interesting with parents is that often the parents will say, well, my kid is struggling with their weight. I want you to help them. And we talk about what's going on in the family. And, sometimes the parents want their child to make a change in their diet, but they themselves are not willing to make that change. And that becomes a huge barrier for success for that child. I've even spoken with parents where the child with overweight or obesity is made to eat like a different meal than the rest of the family, and even including their siblings. And so what message is that sending to the child? It's not a healthy one, I'll tell you that, and it's not beneficial. So I think, to your point, getting family buy-in is essential. The data on adolescents is mixed. It's not as clear cut with the adolescent population, particularly as they get older. But I think family engagement, when possible, is very beneficial, very helpful, regardless of what age we're talking about. So in our current intervention, parents are involved. We have 15 sessions, and of those, 3 parents come to, and we do some of it together with the youth, and then some of it separate with the parents. And that was really, I think, very helpful. One of the things that we do together with the parents is we take them on the grocery store tour. So that's the 3rd session that we do with our kids, and the kids and the parents come and do the grocery store tour. And, we talk all about like how to make healthful choices on a budget, all those things. And it seemed like it was a beneficial thing. Okay, so I'll take one last question before we wrap up. So Lauren asks, what is one piece of advice you would give a current PhD student to be successful as a PhD RD? The one piece of advice I would say is, be passionate, be persistent, you know, people told me it was a mistake to move forward with doing the PhD RD. And I disagreed because that was something I was passionate about. I thought it was important. And so being a PhD student, you know, is something I've learned to be successful in academia or in most things in life. It's not about being the smartest person. You don't have to be the smartest person in the room to be successful. I know I certainly am not the smartest person in most rooms that I am in. But it is about persistence and finding something that you care so deeply about and that you're so passionate about that nothing and no one is going to get in your way of achieving that. You know, the research that I do matters so much to me. It keeps me up at night. I dream about it. I guess it sounds kind of silly, but it's true that I wake up sometimes in the middle of the night thinking about a patient that I saw or a kid that I'm working with, or how, you know, food insecurity influences eating behavior and risk for obesity, and, you know, how can we improve food security and all these things. So I think the important thing is really just finding what you care about, finding what you love, and you'll be successful in that. So thank you all so much again for tuning in and for your wonderful questions. And I kind of like this whole Facebook Live thing. Maybe I'll try this again on my professional page sometime. So just to wrap up, you can follow me on Twitter at Michelle Cardel, on Instagram at Dr. Michelle Cardel, and on Facebook, I have a Facebook professional page at Michelle Cardel. So thank you all again, and please feel free to email me or reach out anytime if I can ever be of help to you all. Take care.